So it's really exciting to be sharing the progress we've made in this study on behalf of my collaborators. I'm Jenny Lane. I'm an orthopaedic surgical resident and PhD student here in Oxford. So it's thought that around 2/3 of breast cancer is hormone receptor positive, and therefore blockade of female hormones that can drive cancer growth is included in treatment for many women. This is used both in the treatment of primary cancer and in preventing recurrence. Tamoxifen was the traditional treatment of choice for estrogen inhibition, but in the early 2000s, aromatase inhibitors were first introduced to prevent the peripheral production of estrogen by preventing androgens converting into estrogens. Two main forms exist, non-steroidal and steroidal. Large randomized control trials have shown significant improvement in breast cancer survival and time to recurrence with the use of aromatase inhibitors in postmenopausal women. Several of these trials have also investigated musculoskeletal symptoms as secondary outcomes, suggesting an increase in these events for women, particularly carpal tunnel syndrome. There's a biological plausibility for the mechanism by which AIs may cause these symptoms. The role of estrogen has been well documented in osteoarthritis in animal models, and reduced expression of aromatase has been found in tissue taken from patients with hip arthritis. Arthralgia, so joint pain, is commonly reported as a side effect with AI use and has been reported as high as 50%, especially within the first year. Tendinopathies have been reported in the literature to occur in AI use, but these are only in small case series. So this study was therefore planned to ask the question, in postmenopausal women with breast cancer, compared to new users of tamoxifen, is there an association of tendinopathies, osteoarthritis, and carpal tunnel syndrome in new users of aromatase inhibitors? Obviously, according to Odyssey's Principles of Open Science, you can read all about the study in its registered protocol that was placed before we started. And the QR code given here will take you to the GitHub page where you can find all the code and the link to the Shiny applications that I'll be talking about later. So the study follows a new user design with comparative cohorts, where the target cohort are new users of aromatase inhibitors versus new users of tamoxifen. The patients included must be age 55 or over, have a diagnosis of breast cancer as was generated by the LEGEND study, and be recorded as female in their notes. To replicate the RCT style design, they cannot have used the other drug previously, and they need to have a year of data prior to starting the drug to give sufficient information about their past medical history and their demographics. We've also made some secondary cohorts to compare steroidal and non-steroidal AIs, and to exclude women who take bisphosphonates due to the theoretical potential for confounding in the OA outcome. Our outcomes are broadly osteoarthritis, tendinopathy, and carpal tunnel syndrome. These are made into 26 individual outcomes that include a broad definition of any osteoarthritis or any tendinopathy, and then smaller outcomes for each condition separated by their anatomical site, or if they represent a medical diagnosis or undergoing surgery for the condition. And women are excluded if they had the outcome noted in the year prior to starting the drug. This is a collaborative project between us in Oxford, CIDIAP in Catalonia, Columbia and Stanford in the US, AGU in Korea, and IQVIA and Janssen. And in order to ensure the study could run throughout, we spent quite a lot of time iterating over our cohort diagnostics that you can also have a play with. It's now been run in 18 datasets and across 9 countries, and this has been a really exciting process where we've had 3 iterative rounds, and we've focused on ensuring that the time frame for inclusion marries up to the introduction of AIs into practice, and that it could differentiate appropriately between surgical and medical outcomes, and also to consider which datasets should or should not contribute to analysis depending on what they represent. And this has fed into a final analysis plan that looks like this. In the main analysis, new users are included after the 1st of January 2006, and they are then analysed in an on-treatment or an intention to treat approach. Intention to treat is followed for 1 year or 5 years with a Cox proportional hazards model using a propensity score matched approach. We've got 73 negative control outcomes and a meta-analysis planned if the I-squared is less than 40%. And due to our findings in the US data surrounding the change in surgical coding from IC9 to 10, We're also running a sensitivity analysis starting the cohorts in 2015 to determine if a difference in outcome is generated due to the coding change here. And we also plan to work with Mark Souchard's team at UCLA to develop the study to adjust for the competing risk of mortality in datasets where reliable death data is present. Well, everyone likes spoilers, so I thought it'd be rude not to include some. And here are the diagnostics from CPRD, which, at least so far for the UK data, appears to show that our design will meet our criteria in terms of covariate balance after propensity score matching for observed confounding and the systematic error controlling for unobserved confounding. And when we've further analysed and we've further run the final study, the Evidence Explorer link in the GitHub will become live for you to look at too. So I'd like to thank everyone who's collaborated, who continues to make this study great, and also everyone who's helped me learn so much about how PLEs work over the past year. And we'll keep you posted on what happens.